Hello, good evening. I'm Siddhant. My question to you is Mr. Himanshu, which we were talking about Abha ID creation. Sir, I have created my Abha ID before 3 years back, but I don't know what is the use of that. Working in healthcare industry for last 10 years, uh, once we go to hospital, any hospital or any lab or clinic, so there we have in private. I'm talking about private hospital. So there we have different HIAs, different LIAs. So how does it link with the private HIAs or LIAs? And second question is that you shared about that you go and ask their what is that HFR ID, HPR, I think so. HPR, yeah. So even we don't know the what is HPR, how we'll ask the HPR. Even the staff of the hospital, they do not know what is ABHA, what is HPR, how we are going to tackle this.
So, to summarize, basically what you are referring to is the IC and the awareness part, nothing on the technology side. But see, as far as the, I would say, mission, goal, or statement was concerned, the mission was made voluntary for a particular reason, that it should not be coercion on the citizens to make you adopt these things. Because as soon as we make it, I would say, mandatory, it becomes a huge compliance cost on the hospitals and a huge and steep learning curve for the citizens. So right now, this is the idea that we have kept it voluntary. This is something which I want to state out. Now, with respect to the use cases of ABHA, so the voluntary side of mission also applies to private sector, right? So therefore, what we have been able to do actually in the last 3-4 years is to onboard a huge government system onto the ABDM ecosystem. So all the government health programs, be it your RCH, Nikshay, Coven, you can even the state health programs of government of Rajasthan, Chipsy, TECO, all these are ABDM integrated, and all of their records are linking with ABHA. Now, I want to state it out, and this is again my personal view, not of the organization which I represent, but this has been generally, I would say, in our country, that the rural citizens, I would say, have been beneficiary of those things, whereas the urban citizens, because of their reluctance or might be convenience, that they don't want to go out and make their ABHA in the first place because of the privacy and security concerns, have been left out because of this mission. Whereas right now, as I said, all the government health programs are integrated. So all the citizens in the rural India have at least 10 to 15 health records linked onto their ABHA. And therefore, the request which I made was also to demand the services from the private healthcare ecosystem. I assume as a private citizen, you would be taking your healthcare from entirely from the private sector. You would only be interacting with the government sector when it comes to vaccination or immunization. That would be your last touch point when you had interacted with the government sector. But when you go to a private sector, you are paying for the money, so you can demand the services, and that's what which I would say the request which I also laid today, that you have to demand from the private sector, because the entire mission is voluntary, and the transaction between a private citizen and a private hospital will also be voluntary. So if you demand, then it will be game of demand and supply. So you demand, they will supply. That is something which will come. Coming to your second question, the HPR and HFR, again, government doctors have their HPRs and HFRs. Private doctors, again, same response, I would say. You'll have to ask the doctor that whether you have an HPR or not. There would be certain things which will fall onto us as citizens if we want to demand digital health services. If you want to, again, this is me speaking as a private citizen, I don't want this to be mandatory. It is up to us. We have to ask. And then the private sector will follow the simple demand supply curve. Yeah.
Sir, one thing is कि हम लोग जो कह रहे हैं कि यूपीआई हाउ यू बिकम सक्सेसफुल, जब ये हमारा जब करेंसी जब गवर्नमेंट ने रोल बैक किया था, तो दैट और चैलेंज वाज कि हम लोग पास कुछ चेंज होता नहीं था. वी डो नॉट हैव द करेंसी कि हाँ तब उसके बाद वी वेंट टू द मार्केट, भैया सब्जी लेना है 1 किलो आलू दे दो, चेंज नहीं है. तो how, so that has the transition has taken something like that. Will this, how will you do this, sir?
Okay, let me correct you there. What you're saying was a denomination of 500 and 1000 rupee note, but what you're saying actually is a smaller denomination which was not demonetized. That is point one. Point two, 70 to 80% of UPI transactions still are less than 2000 rupees. Right. So it was a voluntary choice which as a citizen we picked up because we found convenience in it. Right. And the products have become much better and better. And then again, what I would refer to what Dr. Nina said about you have to provide the data. And that's when the apps will become much more smart and much more convenient and much more responsive to your needs. How many have interacted with the healthcare applications in the past? Until unless you don't interact with the application, the private sector application won't also get your data. That what are the features you need? What are the services you need? Unfortunately, this is a general healthcare seeking behavior in our population, which is very low. So we have a, I would say, episodic mode of going to healthcare facilities. We don't treat our health in a wellness manner or in a preemptive manner. So these are the things which we'll have to think about as society, as citizens, that am I going to interact with the healthcare applications? I'm not saying that you have to monetize it, but at least be aware about our health. We think about our health only when we get to hospitals. That has to change.
Just for information, UPI actually came in after demonetization. I still remember I was part of Ministry of Electronics at that time, and the work on UPI was done on war footing to ensure that citizens are comfortable. So it's not that UPI was actually helped by demonetization. It came after demonetization. And I think Government of India really worked very hard to ensure that actually it was there in time so that the discomfort is reduced.
Yeah, hi, Inka here this side. So I just had a query in my mind that this Abha ID that will give the information, if we give a consent, it will give the information of our health or whatever the details are there to the new hospital or new doctor, whomsoever I am visiting. Will and when we make a medical claim, suppose suppose someone is admitted and he has to go for an operation, there will be some prescription by the doctor, and then we submit that hard copy to the insurance companies. So just by sharing the Abha ID to the insurance company, will it help? That is first question. Second will be that if my information is with the insurance company, will it impact my premium which I have to pay in future? Or it, in other words, can it be misused by the insurance company? Is there any law or rules and regulation to protect that? Thank you.
Okay. I have a clarifying question. When you said that Abha will help in what? Your claims insurance?
So it's all about the passing on the information of my health. So suppose, yeah, at present, as you are aware, if you want to make a claim before going for any operation or more than 24 hours of hospitalization, the information wherever you have been admitted, that details has to be shared with the insurance company.
Correct.
Yeah? So will Abha ID help that?
Okay. Apologies on my side. That was a whole different 30-minute presentation which I did not cover. So there is something called National Health Claims Exchange, which is again part of Digital Health Mission, which we are which we have built, and 95%, more than 95% of health insurance companies are using that platform, National Health Claims Exchange. Right now, we are in process of onboarding hospitals onto it so that hospitals send your claim through the National Health Claims Exchange. And by hospital, again, the problem which the gentleman asked, you will have to ask the hospital, demand that, okay, you link my records with Abha and send it through NHCX to the insurance company. So as far as the insurance side is concerned, we have taken care of the insurance companies through the regulator, because IRDI, we have built the NHCX, the National Health Claims Exchange, with the regulator. So the supply side in that sense is sorted. The demand side is something which again, the hospital and the citizen will have to be on, I would say, the same terms. So you will have to give the I would say, push to the hospital that please use Abha to send my claims to the insurance company. Because there are other numerous benefits. I don't want to, let's say, spend much time on it. But the second point which you said about the premiums, again, all the health insurance companies, because they are using NHCX, so they have the capability to capture ABHA. That is one. And second, also get your past health records. Now, I don't see anything wrong in this. I will say two reasons here. One, right now also, if you have to take an insurance policy, health insurance policy, they get your test done, right? And this is again going back to ma'am's first point, was deduplication, right? They are incurring a cost to get you, I would say, get your diagnostics again, so that they can underwrite your policy and give you a premium. Because of this, because right now the citizens do not disclose their information correctly, the healthy population in the country gets penalized because the unhealthy ones do not disclose it. So this is a collective penalty onto all of us. Right now, insurance companies usually grade your premiums in age segment: 50 to 55, single premium; 55 to 60, single premium. So that hurts a certain section within that also. So they are not thinking that at 55 you might be healthy. They are taking a generalized view and giving you a larger premium. So as we say personalized care planning, this will also come into being, where personalized premium in insurance premium would be can be given to you. So provided you are healthy, so you will get that benefit by sharing that information. Withholding the information, I think, only going to get you in, I would say, bad books of the insurance company. So when you will go to claim that health insurance, they will give you a huge penalty, or they will give you co-payments of 50%. So while claiming, you'll get that bad experience of insurance company. So I think it is in our best interest to disclose those information upfront, rather than getting those inconveniences when you are admitted in the hospital. So I think this is a notion we ought to change, that disclosing an information is not a bad idea in my view.
Well, this is now as a clinician, I am asking certain clarifications. Well, before that, I must tell you, in private sector, we, the doctors, are using digital health much more than the government doctors, because obviously they would not like to interact so well. But in private sector, we do. And we are on, COVID taught us, and we adopted it and became a part of us now. Like, I'll give you an example. I have patients from all over the country consulting me, from Bihar, from Varanasi, from Tikamgarh in Madhya Pradesh, from Bhopal, different areas, and also one of the higher functionaries of this organization, International Patients Union. Her father was also seen by me on this thing also. We all see the patients depending on the needs, but certain things are coming up which is required. That is it. We have to develop certain protocols for patient examination. That's important, so that a proper uniformity of patient care can be maintained everywhere. What I do is, I'll tell you what I do is also solution. When they come to me for physical consultation, then I tell one of the family members, that's what I want to see on that particular thing. If they're not coming to me, in that city only, either their family doctor or some doctor friend, somebody, I usually request them to arrange for one. So I ask them to demonstrate to them, that this has to be done this like this. Neurology is a subject where you have to examine instead of seeing the reports only. That's only has to be correlated. And I have developed a particular way of doing it. And I find it very, very easy to do it. That I would like a protocol for different specialties should be developed, where patients can be seen from a distance, like video conferencing, especially video conferencing. Then number two, what Dr. Pahuja was saying. I was also in Max, I was senior director for some time, then I quit there. This problem, because I am usually patient-centric, I usually take a lot of detailed history. I was finding it very difficult to go into that. I developed a scenario, what Amitabh Nag has already said. What I used to do is voice to digitalization. I would speak, it would type. Later on, I would previously we only record, and my coordinator will type it out, or I will later on type it out. Or later on, when it came voice to digitalization, This can also done. Here it comes, the new technology which is coming up now with the what has been signed, MOU or other things have been signed, of a Starlink. So in the even the rural areas, we'll have to have, we can have every person, most of the people who are working there or going there have a phone, mobile phone. Their complaint can be also taken in, and any language, it can be transmitted by your Bhashini. That can be utilized. Important thing is in the EMR, what I have found is, I still believe in that, most of the EMR, as far as the medical data is concerned, may be a little defective somewhere. But one person's interpretation of chakkar will be different than other person's interpretation of chakkar. Chakkar, somebody gets a really vertigo, somebody gets blackout, headache, or somebody gets even heart attack, they call it chakkar. They fall down, it's chakkar. So there are different things. Here in Dora aaya. Malum pada usko dame ka Dora aa raha tha, he is writing epileptic attack. So these particular things have to be clarified later on. But so solution we have found it out, because right from the beginning, what we find is digital health, if it has to be extended to the patient, it should be patient-centric. And we ought to see one particular thing very clear. See, UK is a small country, but they have a UK biobank. America, during COVID, they produce BDC for 3 years, 21 to 23, September to October, 21 to 23, October. They collected data of people having, I'm coming to a reason why I'm speaking that. They collected data of about 10,000 people, patients, after the COVID, a sample of them only, who are having different symptoms or continue to have different symptoms, more than 3 months, more than 6 months, even a year or so. That's why CDC, the ultimate authority now in America, CDC, has declared one disease as a chronic serious illness. Word used is serious illness, which unfortunately has not been, we have not addressed it in our country. We have not sensitized it. UK has got it. European countries have got it. That's a long COVID. In the morning session when I was on the panel, I was discussing that. And we ought to sensitize ourselves with the result that out of our 140 crores of people, we have 500, 400 publications that to the 5 different places. That to not a standard. And one publication which took place in Lancet, that was from Haryana, it says no COVID. Why? I asked people, why no long COVID? I am asking, I keep on seeing the long COVID cases very often, very serious cases. I asked them, why didn't you tell the people, those who came from Hisar and those who came from Gurgaon, who comes to me very often? They साहब अगर बता देते ये कि हमको ऐसा हो रहा है तो हमको कोविड की तरह से हमको भी वो कर दे, ब्लैकलिस्ट कर देते, वो क्रॉस लगा देते थे ना. So that was the thing. We ought to be careful in data collection. So I'm coming to next thing. It is lacking this very good thing, a scheme which is, but it will not be a biobank to us. It will not be medical data collection to us. To really come out with the facts, like long COVID, which is making the people go from running from pillar to post, exhausting their total savings. In the private sector, I know that. They go to cardiology, अरे भाई चक्कर आया, खड़े हो रहा है, कुछ हो रहा है, palpitation हो रहा है, दर्द हो रहा है. दूसरा उसको memory change हो रही है, psychiatrist के पास जा रहा है, neurologist के पास जा रहा है, ये हो रहा है, वो हो रहा है. But nobody is able to connect it to the COVID. You have to connect it to the COVID. And how you do that? In our country, only 45% of the sick patients are in the government hospitals and the consultation. As per the statistical ministry, in the 2018 only I saw one, and today I talked to Dr. Gopal who had come here. We have majority of the patients in the private sector, and they too not in our urban, the hospital where I work, like Apollo, Max, or things like that. They're in the other cities also, other small rural areas. You have other workers, health workers. Why can't they go while in the routine thing and ask for these situations, which can be through Bhashini or otherwise through satellite phone, can be taken as a data. And they are linked to your Aadhaar card or Aadhaar card, whatever you are doing. That will give us a good medical robust data to compete with the rest of the world. Why compete? Yeah, we can be the leader. We should be the leader, actually. What is important is we should be the leader. And we should do that way. There should be good surveillance system. And there should be good monitoring of it. And the long COVID is one thing which is neglected in our country. If I can be pardoned for using the word, we have got to say in long COVID, we have a situation called a brain fog or fatigue syndrome. So if I can say that we in our organizations have developed a COVID fatigue, we don't have a long COVID here in our country. Thank you.
Thank you so much, sir. Any other questions?
Hello.
Yeah, sure.
My name is Sachin. I just want to ask you one technical question. Basically, I'm from hydrocarbon field. I'm an automation engineer, and I worked in critical process plants, hydrocarbon nuclear plants. So when it comes to a data, a real-time data, like we design a system architecture to seal levels, that is safety integrity levels. Okay, in your case, you are collecting huge data every day. So what is your system architecture, and what if the system crashes? What is the redundancy level to this system? Thank you.
Okay. I think wonderful question. First thing, I want to clear, we are not collecting any data. Our entire architecture, as I said, is a federated health architecture. There is no centralized repository of data at any point in time. So your data, where it stays where it is generated, right? So the only thing which we are providing as National Health Authority is an exchange. So the exchange goes down, you will not be able to transact, but the nodes will keep on working. So the idea is to, I would say, also minimize the security risk here. There is no central failure, as I said here. One node is compromised, only that node is compromised. I would say the hackers can't move horizontally in the system. It is designed in that manner, right? Now, as far as the, I would say the other thing which you have mentioned, this is something which I think I would say ABDM is championing in India. For long in India, the software applications which were made in country were not certified by any standards within the country. They used to say we are HIPAA compliant or anything else, right? So HIPAA compliance again is a cost thing. And what we have found recently that we have an active sandbox, and you can take a look over there. Our APIs are in public domain. So you can also sign up in our sandbox and play with the APIs and see how the services are being driven. As far as we are concerned, we are giving, as I said, minimal number of services, which is authentication as well as transference. And as far as, again, the transfer of health record is concerned, the health data also does not pass through our system. We are not even seeing the transfer of that record. We only verify the entity which is generating the consent request. Through our consent manager, we see whether the patient ABHA is correct, whether the facility is correct, and the patient the doctor's HPR is correct. So that is the single source of truth registry. We verify that, and then the data is moved from health information provider to a health information user through a separate link, which is not seen by us. So the data in that sense, even if our gateway goes down, if what you said, the data transference can happen independently. This is not dependent on our gateway. Sorry, the point which I was mentioning, the HIPAA compliance one. So what we have seen that in our Indian market, there are many software solutions which have existed for 15 to 20 years. And as sir has said, the private sector doctor have been using, but they were not certified by Indian agency at any point in time. So they were all running at risks. The software solutions could have been compromised and there would have been no recourse to those things. What ABDM is doing here is that it is bringing all the software companies or health software systems to a particular level. So here to all the doctors who are in this, I did not cover that particular element in this, but if there are any doctors, I think you should also ask the software solutions you are using for generating the HMIS or for creating the health record. Ask the software solution to get ABDM compliance or give you any soft security compliance certificate. Because with the new DPDP Act coming in, if any data leaks happen, you are the data fiduciaries, right? So it is up to you that you use a very robust EMR solution or HMIS solution, whatever you want to call it. ABDM compliance is the Indian standard, but do ask it from your software solution. So this is an, again, ask to the private sector doctors. For the government, we are doing our part. Thank you.